Malcolm, we will start by a few more minutes late, Malcolm. So yet to be 2 o'clock. We'll start by 2 or something like that. How there? Okay, sound over. கேட்கலையா? யாருமே பேசல. நான் தான் பேசுறேன். நான் பேசுனது எனக்கு கேட்காது. இங்கிரு ஓடி கூட. Malcolm, am I audible, Malcolm?
Yes, sir.
If it reaches double digit, we will start, Malcolm.
Oh, yes, sir. Sir, you are still with your mask, sir.
I'm in the hospital. That's what we are. அவங்களெல்லாம் கொஞ்சம் இது பண்ண சொல்லுங்க. Good afternoon, everybody. On behalf of SRM family, I welcome you all to this fifth lecture of a series of 9 lectures. I now request Dr. Malcolm Jeyaraj to give his lecture.
Very good afternoon, sir, and good afternoon to all my colleagues. Thank you for the opportunity once again. I would like to go into today's topic of focal intraictal epileptiform discharges. The focal intraictal epileptiform discharges could be spikes, sharp waves, broad sharp waves, spike wave complex, polyspikes, and in certain peculiar instances only an intermittent rhythmic delta activity. So they can take any of these forms. According to IFSCN, a spike is a transient discharge. It can be clearly distinguished from the background activity. The duration is generally between 20 to 70 milliseconds. It has got a physiological feel. It should disturb the background. The main component is generally negative, but the amplitude could be variable. I'm just bringing a prototype to share with you. A sharp transient you see across F7, T1, T3 in an average montage. It stands out against the background. That's quite obvious. And if you see, the background is quite serene here, but here, the moment the spike appears, seems to be a disturbance in this region. So it disturbs the background, and it has got a feel. So we call this as a interictal a spike, which is otherwise an interictal epileptiform discharges. There are no, as an IED as a whole, there are certain pitfalls. In some instances, it has a in some index cases, it got a low sensitivity. It is in 25% of the patients with epilepsy, no interictal epileptiform discharges are noted. The IEDs suggest a presumed site of origin, but it could be well far away from the ictal onset zone. So we call this as an irritative zone. Sometimes there could be a deep foci that may get propagated elsewhere to be on the surface to be negative. So you may have somewhere much deeper within a gyri in a particular region, but it could be, for example, a frontal spike, which I'll be showing later. A frontal source may be diffusely distributed. So there you cannot localize with the diffuse distribution, and it's got a limited spatial resolution. So broadly classifying focal epilepsies, the symptomatic focal epilepsies could be either temporal in onset or extratemporal or hemispheric. The temporal lobe epilepsy accounts for the large number of symptomatic focal epilepsies, around 70 to 80% of the cases. The extratemporal lobe epilepsy is seen in around 20 to 30%. The temporal lobe epilepsy is further divided into a mesial temporal lobe epilepsy and a lateral temporal lobe epilepsy. So the structure today that I'm going to talk about is I'm going to take each region and analyze what could be the interictal patterns in those regions. The interictal pattern in a mesial temporal lobe epilepsy could take any of the forms. It could be an anterior temporal sharps, a temporal intermittent rhythmic delta activity, as the name implies, a temporal intermittent polymorphic delta activity, and bitemporal IEDs. The anterior temporal IEDs have a phase reversal across T1, T2, and F7, F8. It is accompanied by a diffuse area of positivity over contralateral centroparietal scalp region. It is much lateralized during wakefulness and REM sleep, but poorly lateralized during an NREM sleep. For example, whatever points I told, there is a spike in the wave discharge seen in FP2, F8, and T2. It is extremely sharp, and there is an aftercoming slow wave. If you look at the contralateral, that this is seen in the right hemisphere, you see at the contralateral centroparietal region, there seems to be a positivity. So this is a sharp spike associated with the contralateral positivity. Is a classical type 1 spike. Why we call this as a type 1 spike? Why is there importance? Because the moment you see this kind of spikes, and if you are going to take this patient for an anterior temporal lobectomy, they are going to give very good results. The next interictal IED that you see in temporal lobe epilepsy or a mesial temporal lobe epilepsy is called Tirida. As the name implies, it is a temporal, seen in the temporal region. It is seen intermittently. It is rhythmic. It has got a delta activity, and it's monomorphic delta. And it is considered to be an EEG marker of epileptogenesis. So unlike in other areas where you see delta rhythm, when you say delta rhythm in the temporal chain, it is equivalent to a spike. So significant correlations between Tirida and mesiolateral TLE have been noted. MTLE-HS has been noted, and IEDs have been localized over the anterior temporal regions. And it has got a significant correlation with the 5 to 9 Hz temporal ictal discharge also. Now this is a average montage, and you see in right temporal region a delta activity which is seen in a rhythmic format, and if you compare, it looks alike, almost looks alike. So you call it as a monomorphic delta. So temporal, it is seen intermittently, it is a rhythmic, and it is monomorphic delta activity. So this is equivalent to a spike only in the temporal region. Another variant that you see in temporal lobe epilepsies, especially MTLEHs, it is common, but it is non-specific. It is seen in certain extratemporal epilepsies also. Now this is the right temporal region, and you see a slowing, but the slowing is more of a just got a delta rhythm, but there is no monomorphicity. Each wave looks slightly different. So you call this a polymorphic delta. This is not equal to a spike. The third pattern in which MTLEHs represents itself could be bitemporal IDs. So in 30% of patients with unilateral TLE, they present with bitemporal spikes. And when the lateralization is more than 90% to one particular side, it's got good surgical outcomes. If it is less than 90%, the outcomes decrease. Similarly, when the substrate is an MTLEHs, that is an MTS, the IEDs are more localized to the anterior temporal regions, but in tumors, you have widespread IEDs. So this is a classic. There is a phase reversal which you see across T2, and there is a field. So this is another right anterior temporal IED. Similarly, you see a left anterior temporal IED here. So this is a classic representation of bitemporal IEDs. With regards to IEDs in mesial temporal lobe epilepsies, you have to understand that there could not be any spikes at all, or pterodine 10 to 15% of the patient. And another 5 to 10%, the IEDs could be widespread due to diffuse injuries, but that really does not preclude a good outcome. And temporal IEDs are also occasionally noted in extratemporal epilepsies. Now coming to the second region, that is the lateral temporal lobe epilepsy. The IEDs or the spikes, they differ from the mesial temporal lobe epilepsy in morphology. If you would remember, I'll be showing subsequently a very sharp spike and an aftercoming slow wave in a mesial temporal lobe epilepsy. But in a lateral temporal lobe epilepsy, the waves are slightly broad. It's got wide fields. They can be more lateralized and more posterior temporal. May not be anterior and mid-temporal as seen in the MTLEHs. And they lack the contralateral central parietal scalp positivity. In addition, there could be a diffuse polymorphic slowing across the temporal chain. And occasionally bitemporal and extratemporal IEDs also may be present in a lateral temporal lobe epilepsy. So this is what we call as a type 2 spike. I will show subsequently a type 1 for you to understand what is a type 2, to differentiate between a type 2. You see the spike is slightly broad. It's got an aftercoming slow wave. But there is no contralateral positivity that you should see here in the centroparietal region. And this is also the same type 2 spike. But now I'm contrasting it with the type 1 spike for us to understand. See, look here how sharp it is, followed by an aftercoming slow wave. And you see a classic contralateral positivity, C3, P3. But in this type 2 spike, you don't see any kind of contralateral positivity. So, I mean, the value they say is type 1 spikes are good biomarkers for a good surgical outcome. Type 2 may not. Now, coming to the next region of interest is the frontal lobe epilepsies. Frontal lobe epilepsies could be, it's a common entity as we approach as a frontal lobe. But as far as epilepsy is concerned, there are several regions or sub-regions within the frontal lobe. And each region, the pattern of epilepsy could be varied. I'm not going into that today, but I'm just identifying various epileptogenic regions in the frontal lobe. So they could arise from the front, supplementary motor area, cingulate, anterior frontopolar, orbitofrontal, dorsolateral, opercular, and motor cortex. The nature of the IEDs or the spike is largely determined by the area of the frontal lobe involved. The spike from a dorsolateral that is the eye field and the motor area, will behave differently from that of a mesial frontal, which will behave differently from that of an orbitofrontal. Now, the pitfalls are in with regard to EEG and frontal lobe epilepsies are, this is the most important point. These two are the most important points. There are large areas which are relatively inaccessible. So in the frontal lobe epilepsy, if you don't find any kind of spike, I mean, it doesn't reach much concern. But you have to be more careful because many of the frontal lobe epilepsies can mimic a non-epileptic event. And in those cases, if you are unable to find a spike or an enterical epileptiform discharge, it does not rule out the possibility of a frontal lobe epilepsy. So the areas that are relatively inaccessible are mesial frontal, orbitofrontal, and sulcal depths. They know there could be no IDs to widespread IDs. Secondly, the frontal lobe is extensively, there's got extensive communication. So there can be bilateral and contralateral spikes, ipsilateral temporal spikes, and multifocal or generalized spikes. So as I was trying to explain, spikes on this surface could be unilateral, well localized, but spikes on this surface, the mesial surface, or in the orbital surface, it's not the real orbital surface or the undersurface, can have no to diffuse IDs. So that will give us a clue as to where it is arising from the frontal lobe also. So the frontal epileptiform patterns could be no, in 20% of the cases, there could be no spikes, as in mesial frontal epilepsy. There could be bifrontal to generalized spikes in 30% of the cases. And unilateral discharges are seen in only 40%, especially from the dorsolateral frontal. And sometimes the orbitofrontal lobe epilepsy can manifest itself only with the temporal spikes. And we have to be very careful because it's a surgical point. So when a patient presents to us with a seizure that has got a temporal pattern, the origin could be very well from the orbitofrontal. So this is a average montage, and you see a very unilateral spike in wave discharge along F4. So this is part of the frontal lobe epilepsy syndrome. So this is one particular representation. So in instances that could, as I am telling you, there is a focal particle dysplasia, which is here, which is seen right frontal dorsal region, and it is producing spike in wave discharges over a right frontal and maybe slight extension in the right temporal. So these are discrete, well lateralized or unilateral, and they are confining themselves to certain particular leaves. But on the other hand, the frontal lobe epilepsy can manifest something like this. This is looking like more of a generalized paroxysmal fast activity. So you see widespread discharges. And sometimes they could be seen in the midline. They're seen in FZ, CZ, F3, and C3. This could also be one particular kind of representation. So the next is it can have an orbitofrontal presentation. I'm sorry for the diagram. It is seen an orbitofrontal lesion, especially can manifest itself only with temporal lobe spikes. Only with temporal lobe spikes. This could be a real mimicker, and you have to be extremely cautious about this. So the occipital lobe epilepsy is the next entity that I would like to talk about. The enterical patterns which are seen in an occipital lobe epilepsy, there is could be having various formats. Not necessarily it should have a spike. There could be a unilateral reduction in voltage. For example, when you compare O1 to O2, there could be a decreased amplitude on one side. There could be an asymmetric photic response which is seen on one side. Loss of alpha seen on one side, and asymmetric post. All this could be markers of an occipital lobe epilepsy. Not necessary that it should have a spike always. As far as IEDs in OLE are concerned, it is largely of two types. One, it is restricted to occipital and posterior temporal region, or rarely it would have a bilateral spike wave activity. The etiology also determines how the spike is formed. In the case of an FCD, that could be a very focal spikes seen in the occipital or posterior region, and it could be frequent in rectal spikes. But in the case of a porencephaly or a large lesion, IVs are seen more over the posterior temporal regions than over the occipital because there is no tissue to represent it. Now, coming to the pitfalls as well as the intrarectal discharges in OLE are concerned. The mesial, as I said for mesial frontal, in mesial occipital and deep calcarine, the IEDs may be difficult to detect or it could be widespread. So there is another issue. I mean this points are more of a surgical nature, especially when you try to understand a very focal spike that helps us to select the patient. A diffuse spikes may say that this patient is not the right candidate for the surgery also. So you see a very intense focal spikes here, the P4O2 region. So positive to negative. So P4 is positive, O2 is negative, and it's got a downward deflection. So this is a P4O2 spike. Sometimes you may have rhythmic spikes which are lateralized. Or you can have apparent bilateral spikes over the posterior head region, bilateral spikes. Now, this is another very unique entity that helps us in certain patients, namely these small spikes. I'm sorry for this, I'm not able to remove it. So is the screen visible, sir? Hello?
Visible, Malcolm.
You see some focal rhythmic spikes. Now we found that many of these patients with the focal paroxysmal fast activity have epileptogenic substrate base in either they have a gliotic lesion, a scar-like lesion, or in some patients there may be a focal cortical dysplasia. So whenever you see this, a very unilateral occipital spike, which is very significantly lateralized, and you have a pattern like this, the initial MRI report may be normal, but it's very important to go back into the MRI and check whether there's an FCD or a gliotic lesion. This is what I'm trying to tell. Focal rhythmic spikes or a focal paroxysmal fast activity that you are seeing, or beta activity which you are seeing on the right occipital region. Now coming to my last entity, especially the parietal lobe epilepsy. The parietal lobe is one of the most difficult epileptogenic substrates because the parietal is almost like an integrator. It's got widespread connections and ramifications. And subsequently, the IEDs are also extremely widespread. And rarely only there could be no IEDs. False localization to parietal lobe is the rule rather than the exception. There is a localized, and you see in the P3 average and O1 average, a spike that is going on. Very, very rarely you see the focal epileptiform discharge, and it is localized itself to the parietal electrode. Extremely rare. This is not the rule. It's rather the exception. The rule is widespread IEDs. These are the rule. This is the rule as far as the parietal lobe epilepsy is concerned. Now coming to the last entity are the IEDs which you see in hemispheric epilepsies, and many times this is the pattern. If there is a huge widespread lesion, complete atrophy, or a huge porencephalic cyst, you may not see any kind of spike on the side of the lesion. To our dismay, you may find that most of the spikes are seen in the contralateral side because of volume loss, and there is no brain tissue to express the intrarectal epileptiform discharge. Another common presentation could be a unilateral slowing, as you see in this case, a very, very clear-cut unilateral slowing to one side, or as I told you earlier, contralateral IDs are more the norm, more the rule rather than the exception, especially in cases like Rasmussen encephalitis or a huge porencephalysis. Most of the spike burden will be seen on the contralateral lobe, or the ictal discharge would be seen on the contralateral lobe. So before I conclude, I would like to just summarize and say, so identification of various patterns of intraocular epileptiform discharges is very important. It could be a spike, sometimes it could be a sharp wave, sometimes it could be a beta rhythmic activity or focal paroxysmal fast activity, or rarely it could be only an intermittent activity like in Tirida. It has got great localizing values in certain patients. But in some patients and in some substrates, there could be widespread ramifications. And the third possibility in most of the cases, in some of the cases, could be there would be no IEDs also. So always correlate the spikes or the intraocular discharges in tandem with the epileptogenic substrate or the clinical scenario to achieve a better diagnosis. Thank you once again, sir, for the opportunity.
Thank you, Malcolm. It was a nice presentation.
Thank you.
I request the audience to come out with any questions they have. I think IIN is going on, I think.
Yes, sir. Yes, yes.
It's a bit less. We didn't know the date and all.
No.
Anyway, Malcolm, thank you. Thank you very much. And
Awesome.
that is only one question I want to ask, Malcolm. It's a
Yes,
general
sir.
one.
Yes.
What percentage of EEGs in epilepsy patients come positive? Positive findings. How much percentage usually come positive?
It depends on how the EEG is done, sir. If you do an awake EEG, only an awake record, the yield may be very low, say around 30-40%. But once you do a good sleep record, even if it is for 1 hour, the percentage would rise somewhere around 70-80%. So it cannot be told uniformly. It depends upon the duration to which it is done, the wakefulness state versus the sleep state, and the presence of activation procedures, which will increase the yield of a EEG.
Routine EEG taken in the hospital, what will be the suggestion?
With an awake and sleep should be around 60-70%.
Okay. Okay. Any other question, anybody? Okay. If there are no questions, we will wind up this session. And I thank Malcolm again, and we will be meeting again in another EEG in ICU, I think.
Yes.
We'll come out with the link and everything later. Thank you. Thank you for all.
Thank you for the opportunity. Thank you.